All right, good morning, everyone. How's everyone doing? My name is Efrain Talamantes, and I'm a second-year Robert Johnson Clinical Scholar at UCLA, and also supported through the Veterans Affairs program. And in a nutshell, what that means is that I've completed medical school at UCLA, then went on to Emory University to complete a master's in business degree, and then did my internal medicine residency here at UC Davis, at the UC Davis Health Center in Sacramento, and then worked for a year, and within that year decided that I wanted to go back to school and be a clinical scholar, meaning that as a clinician, I'm interested in big research questions that will eventually lead to improvement in health. And one of the areas that I focus on is diversity. Diversity is very dear and near to me, partly because I come from I'm a first-generation college student. I come from a Mexican background. Both my parents are from Jalisco, Mexico, very small rural town. And throughout my experience going through this pre-med pathway, as many of you guys are doing now, sort of became intrigued by the fact that there is an underrepresentation of certain minorities within medicine, and I wanted to know why. And so this kind of this is 15 years of my experiences and work in thinking about this issue. And my goal would be to really help you guys understand diversity, not only from my perspective, but also from the health system's perspective, why it's important for health and why it's important for our patients. As a clinician, I get to take care of a lot of different patients from very different backgrounds. And some of the challenges that are always hard for me to deal with are language, cultural, and other sort of diverse perspectives that people bring to the table. And sometimes having that openness to understand those issues makes me a better clinician and makes me more effective so that my patients get better. So what I'm going to do today is go through a little bit of a historical background, give you guys an understanding of where sort of medical education reform started back in 1910 with the Flexner report, why we have underrepresented minorities, why there's certain classifications that have been made not by individuals that are pre-med or medical, but the actual institution of the Association of American Medical Colleges, how they define URM, how they're defining and redefining it, and then the opportunities and challenges for diversity in a very complex world where we know that in terms of advancement, it has a lot to do with the social determinants of health, social determinants of education. And many of my students who are applying to medical school right now, the most common question you guys will see, not only in your secondaries, but when you interview, is why is diversity important? What is it about yourself that brings that diversity to this medical school? And so it doesn't matter where you come from. It is very important to understand, because when it comes down to patient care, that's what our patients want and that's what they need, right? So let me just take you guys a step back. About 100 years ago, the life expectancy for white men was about 50 years old. White women was a little older. And that's still the case today, but obviously we've made tremendous advancements in medicine. But even then we had disparities. We knew that African American, black individuals lived a lot less. And so understanding that, we come from a society, a country where there was already existing health disparities, we sort of began to think about reforming medical education. And many folks would credit W.E.B. Du Bois as sort of the visionary of understanding what was going to happen 100 years later. The fact that the problems in healthcare specifically, now in the 21st century, are really problems that have to do with race, And partly, it's because that's where we see the greatest health disparities. And we'll get a little bit more into that. And so W.B. Du Bois was the first black man who went to Harvard University, got his doctorate degree, and went on to Atlanta, where he did a lot of health disparities work. So I would credit him as being one of the founding fathers of understanding health disparities back in 1800s, late 1800s. So one of his first studies looked at city problems in Atlanta, and he was trying to understand what the mortality, or why. I mean, people knew that the mortality rate for black men was higher, and so he put together sort of a demographic study looking at who was dying and where throughout the South and the East, and sort of recognized that colored folks were dying or had a higher mortality than white folks. And so he actually went on to describe why, and many of those issues had to do with where they were working. They were working in conditions, and obviously we understand the history of slavery and all those factors, and those were directly impacting people's health. And so now you would say that in this day and age, a lot of immigrants who come from mainly Latin American countries are also in the same shoes, where they're working really tough jobs, and many times that leads to injuries or harm that would cause them to have a higher mortality than others. So you see that the mortality rate is twice as high for colored individuals back then compared to white. And so how many of you guys know who Flexner is? No. So Flexner put together a report. You can Google it yourself. You can read a lot about it. I would say he is the individual who really envisioned what type of healthcare system we have today. And we can credit him with, allowing us to have an extended lifespan, because he really focused on medical research and making sure that everything we did as clinicians was evidence-based. And this was really the beginning of how do you take research, apply it to health, and make health better for people. Instead of just kind of doing a lot of hokey-pokey type stuff that we used to do, like leaching to treat pneumonias, or bloodletting in other ways to treat infections, right? So if you came into the hospital, you had a pneumonia, they would allow blood to just drain out of you, right? Which doesn't really make sense to us today, but that's sort of what would happen. And so he traveled throughout the country, not only here in the United States, but also in Canada, and he started to describe what was going on in the medical institutions. How are people getting trained? How is it that they become physicians? And he noted that there was wide variation, right? There was some institutions where people were getting superb training, quality, they were doing quality research that was supporting what they were doing, and other places where that wasn't really what was going on. So his highest aims were, how do we improve health, understanding what's going on throughout the country? So then he closed down all for-profit medical schools, because most of those institutions had other incentives to move forward, and really created a model for reform for modern medical education. And modern medical education really had to do more with how do we improve the care we deliver to patients so we improve their health. And so this is UCLA. This is where I did my hospitalist work and trained future doctors. And you can see that the beauty in having hospitals where right next door there's a medical school, right next door to that there's students, creates a great environment for teaching and learning. And we can credit Flexner with that, because every institution that didn't have a hospital associated with it, or couldn't afford to have a hospital associated with it, was shut down. And so, in essence, every medical school had to be integrated with the university with enough money. They had to have high quality training and professional standards. So you can thank him for the MCAT and step 1, 2, 3, and all the boards we have to take. And again, really focusing on research and making sure that medical research was the foundation for what we did. And then admission standards, how we actually look at individuals and admit them to medical school. And so, at the time, as I began my talk, we knew there was health disparities. We also knew there was extreme racism in the country, after times of slavery, and there was different medical schools for African Americans, and there was different medical schools for white students. Knowing that, there was really no support for any African American medical schools. So the standards were all the same, and you can sort of think about it and say, well, that's fair because we need to make sure that all the doctors are performing at a certain level. And many patients actually wouldn't go see an African American doctor because they knew that they weren't as qualified or trained because they weren't going to the best institutions. So in putting together his report, he sort of alludes to the vision of the black physician in America. And so this is where we begin to see sort of a separate but unequal beginnings of education, medical education for minorities. So let me just read this quote. "The Negro must be educated not only for his sake, but for ours. He is, as far as a human eye can see, a permanent factor in the nation. He has his rights and due and values as an individual, but he has, besides, the tremendous importance that belongs to a potential source of infection and contagion," right? So if you think about where most African Americans lived, they were living in really extreme poor conditions where there was no potable water, where there was a lot of infectious disease. And so he almost articulated a vision for the black physician to take care of these patients, but to be more, sort of hygienists, not really true physicians. And so the purposes of the Flexner report, the beginnings of our institution's vision for diversity is very limited because you can see that the consequences are that there's a restriction in the production of black physicians from the beginning. You create a structural racism within academic medicine, and there's a limited role, like I said, for diversity in medical education and the physician workforce. I mean, the purpose, of course, as I've mentioned, is that it brought the U.S. medical institution to being the #1 medical education institution in the whole country. But, in thinking about if you were Flexner trying to develop a vision for the medical education system, could you have done something? Could we do something today to think about how to deal with these consequences? So many people would say, well, what are you talking about? What consequence? I don't understand. It doesn't make sense. So if you look at the historically black medical schools, there was only 2 that were left open. 2 out of about 8 medical schools were left open. And these medical schools that were left open, Howard and Meharry, who remain open today, have produced 75% of black physicians from 1910 to 1960. And I'll show you some data that updates this. But you can kind of see that you begin to cut off the training for black physicians from the get-go, and you only give the responsibility for black physician training to 2 medical schools when there's hundreds throughout the country. And so we're starting in, again, separate but unequal state. And so this brings us forward. Where did our national medical associations take a stand? And early on, because of the political environment, the National Medical Association stated that they would not allow themselves to get involved with any sort of admissions policies to fix this. And it wasn't until 1968, after the National Medical Association sort of really pushed and said, hey, we need some help here. The National Medical Association is representing all black physicians at the time in the country. So it wasn't until recently, 40-some years ago, that the AAMC and the AMA, the Association of American Medical Colleges, began to sort of endorse this expansive role of a vision for a healthcare system where any student who was qualified, who had worked hard, who had gotten the GPA and MCAT score that they needed could get into medical school. Before, that was not the case. So obviously this really started with the civil rights movement, where you can really start to see that you have rights to get into medical school as a minority applicant. And so, when you think about diversity from the beginning and after the civil rights movement, it starts off with awareness, right? The doors are open. If you guys want to go to medical school, you can get right in. There's no real sense of how do we really support these students who have been left out of the education system from a very early age, who have been educated in systems that have not been as well-resourced as others. And so you can kind of see that this sort of evolves into various efforts once people realize that you can't just open the door and say, you can come in and get into medical school, because there's no one applying in terms of African Americans. And now we're starting to see a lot of diversity in terms of Latinos, Asians in the country. And so now you start to bring in legal action from the top, because obviously this is a rooted issue that goes beyond just medical education. It goes all the way down to pre-K education. And so it takes the establishment of the Office of Minority Affairs to really start to look into these issues, to start to develop strategies around how we actually not only make people aware, but we actually try to recruit people to get into medicine who come from these backgrounds, who've been left out for the last 60-some years, right? And then you have other schools that open up that, again, are focusing on minority students, with Charles R. Drew University, that's in Los Angeles, and then Morehouse School of Medicine. And then there's all slews of programs like the Health Career Opportunities programs that start to get funding from the federal government to help these issues. And this conference is a vision of many students who have truly believe in improving diversity, because they invite all you guys to be here today to get all this wonderful information. So, 100 years later, after Flexner kind of came in, reformed our medical education system, and is really the founding father of our health systems today, you could see that there's a lot of work to be done, right? So in 1968, we had about 130 African American physicians were graduating from medical school. In 2008, 9-time increase, about 1,000. But if you look at the proportion of African American physicians to African Americans, is actually lower today than it was back in 1910, right? So again, how do we think about these issues? And again, African Americans really are the ones that take the lead, because they have the most history here and sort of have really opened the doors and pushed for the rest of us who are coming in, who come from very different backgrounds, to get into medical school. And so when the M.B.A first defined an underrepresented minority in an attempt to figure out how to count students and see how they were doing, they defined it as students or physicians whose representation in medicine are lower than the general population. And the initial definition really was limited at that time to these types of groups. Again, this is post-civil rights. And now, as the M.B.A becomes more and more aware that there's more students, it's not just about race, it's about sexual orientation, it's about religious beliefs, it's about documentation status, it's about all sorts of stuff, we start to broaden the scope. And so now when you think about diversity, and not only to increase the number of minority students for the sake of increasing numbers, but to really understand, well, why are we really trying to achieve this? And so there's been various studies, and this is one by Dr. Saha, who's up in Oregon, who put together an analysis of students at various medical schools, and he sort of stratified them based on how diverse they were, right? And what he noted was that the schools that had more diversity, looking at women, looking at minorities, and a few other factors, the students overall, all students, not just the minorities, would say that they had a better training so that when they went out to residency, they were more comfortable taking care of patients that were African American, that were Latino, that were Spanish speaking, that had different religions. And so it's not just about bringing in a historically underrepresented group into medicine, it's to bring them in because they add value to our educations as medical students, as residents, as physicians. So, now we're moving forward to Diversity 2.0, and it's not just about sort of, okay, now we're getting, we got the strategies down, we made people aware, we recruited them, we got them into medical school now. But it's now to think about the infrastructure within our medical institutions so that these students are successful, right? And what I mean by that is that you can't take, for example, myself, a Latino student who speaks Spanish, and put me only in a clinic where I only speak English and take care of English-speaking patients, right? You got to find ways for me to get training in a place that I feel very comfortable because I speak Spanish and I grew up in a family who speaks Spanish, and I want to take care of patients who remind me of my family, my community, where I want to work, right? Because that's where I'm going to excel. And so you have to figure out ways in medical school, and you'll see there's a flurry of programs nowadays where when you guys get into medical school, not only will you get the best training, but you'll be able to practice in places where you're going to take care of populations that are very difficult to reach for the general doctors, but that you can reach because people feel comfortable with you, right? So if you want to take care of a diabetic who's undocumented, who speaks a different language, maybe you have experiences that you bring to the table that help you connect with that patient so that you can make sure that when you give them advice, it's not like, well, you know what? You just need to buy your medication and take it, right? It's more complex than that, right? Because they have to take 2-3 buses to get to the clinic to see you. You might not know that if you don't ask. They might not pay for their own medication because they have to pay for their kids' medication first, and that comes first, right? You might not think of that. So you start to sort of embed these training grounds within the medical schools to really sort of take diversity to a whole new level. And that's the challenges that, as you guys move forward, you're going to have. And you could say that, well, because I'm a minority, maybe I'm going to be better at this. Not necessarily so. And you can say, well, because I'm not a minority, I don't have to deal with this. This is not about me. This is about other people. Well, guess what? No. Over 50% of your patients that you take care of in the future are going to be minorities, right? And if you've never come across a minority, never understood, how they think, how they communicate, it's very difficult to get them to listen to you. Because when people don't get you, they don't trust you. And if people don't trust you, especially, like my parents, they don't trust American doctors because they don't get that same kind of treatment. It's a 15-minute window. You got to see the patient and get through and send them out with something. And many times in America, we don't want to overprescribe antibiotics, which is a great thing. We don't want to give any vaccines or shots for whatever reasons. And so they're used to a different kind of culture. But you need to address that. You know what, señora? We can't give you antibiotics because these are the consequences. Oh, I didn't know that. But if you just say, well, you know what, I'm not going to give you antibiotics, you got to go. Got to see the next patient. Then you're going to be in trouble. So, when it comes down to healthcare workforce diversity, now you're a doctor. We know that when it comes to thinking about your background and your culture, your language ability, it influences where you go, right? And so from the get-go, we know that students who speak Vietnamese, for example, are going to end up practicing in these types of communities because, again, that's where they're going to flourish. That's where everyone's going to want to go see them because they're the best possible doctor because they can actually communicate, understand, and connect with those patients. And so this is another study that looks at sort of the benefit of diversity within the physician workforce, not in medical school, but now taking a step forward and, okay, now you're a doctor, so what does that mean? So now moving forward in terms of the most recent diversity efforts, we have holistic admissions. How many of you guys have heard of holistic admissions or read about what it's all about? Yeah, and I would say that the majority of us still don't understand this or what that means. And I would encourage you to go to the M.D M.B.A website and find the report on holistic admissions to get a real good sense of all the different factors they're thinking about now. Because it's not just good enough for you to have a strong GPA and a strong MCAT score. It's not good enough for you to have research or volunteer experiences. They really want to kind of see that you're a complete physician. And that has a lot to do with the way the process is designed. The application process is very tedious. It includes a lot of different factors. And every factor that you include in there, they have the opportunity to evaluate. And then you have secondaries, which, again, a lot of the questions have to do with diversity. And then interviews, where you actually get to meet with physicians and other community members in some medical schools, where you're going to interview with them. Most of the time, you'll interview with physicians, but sometimes you'll interview with actual patients. And those patients, again, come with this perspective, and it could work both ways. They could look at you and say, oh, this person thinks they're really smart, they're educated, so they're judging me, they don't understand me. And you got to find a way to break that barrier down. So there is a lot of emphasis on thinking about how to evaluate students to get into medical school. And then now there's post-bac programs for students who, for whatever reason, at some point in their career, weren't really sure about being medical pre-med or thought they weren't good enough to be pre-med because they felt like whatever they brought to the table wasn't being valued, like their community service, for example. They're like, well, medical schools, all they want is research, and that's not true. So a lot of students will go back and do a post-bac program to really beef up and get into medical school. And then most recently, we've had several reports that really emphasize the need for a diverse workforce, and that has all to do with demographics. California, we're sort of, we break ground, we're the first to break ground in all sorts of stuff, including, healthcare and getting people to enroll in healthcare with the Affordable Care Act. And same thing with, diversity. We're the first to have, we're going to be the first to have a majority minority population. And so it becomes very, for the medical schools, it becomes a very important issue for them to address this front and center all the time. And then we have the mini medical or multi medical interviews, which sort of really try to get at this. Because, traditionally, like when I interviewed for medical school, I had maybe 3 interviews per medical school, and that was with 3 different people. And a lot of times it went like, like your first date. You go and you introduce yourself, and you start feeling uncomfortable, or maybe you feel really comfortable, and it might go well, or you might say, I don't want to ever see this person again, right? In the multi-medical interviews, you'll have up to 15 interviews, and so you can have a bad date. That's fine. you move on to the next person and the next person, and you get 15 scores instead of just 3. And so if you spread, all your evaluations over 15, then there's a chance that you get a more fair and accurate evaluation. And it's not just based on whether you watch college sports, because that might not be something you mesh with in terms of the interviewer. And that's what would happen before. So a lot of schools are moving to this model. UC Davis is one of them. UCLA, where I'm at now, is also on the M.D.M.B.A. So this is a chart that sort of goes through the holistic review, and it goes through all the different sort of traits they're looking at and the elements that they evaluate. So again, it's a lot. I would say that it's not to intimidate anyone, but it's just to sort of think about the fact that you guys all need really good mentors, you need good advisors, you need to really rely on physicians or medical students to help you through this process, because it is doable. It's just that now everything really is important, not because they want to make it hard for you guys, but because when you get into medical school, they want to make sure you're prepared to take care of patients. And patients, when they come with their illness and all the issues they have to deal with, it's a very difficult challenge. And so you want to make sure that people are ready for that challenge. And so where are we with underrepresented minority applicants? Again, the focus there, because that's kind of where we have the data, but there's other data that's now emerging that we're looking at. So soon we can have other reports that not only look at race, but you can see that out of about 40,000 students, we only have about 3,500 African American Latinos apply. And again, the question goes back to, well, why? Where are all the Latinos? Where are all the Black and African Americans? Why are they not applying at a higher proportion to medical school? I don't have it here because I just got this data, but if you look at the proportion of, for example, Asian students, overall, everyone starts around 3% right after the Civil Rights Movement in the 1970s. There's 3% Asian Americans, 3% Black, 3% Hispanic, and over time, African Americans have leveled off around 5 or 6%. Latinos have also leveled off around 5 up to 7%. It kind of fluctuates. Asians went from 3% to almost 20, 22, 23%. And so you can kind of see that and if anything, white applicants have dropped. And so you went from almost 80% white applicants to 60% now. So you see that, and that has a lot to do with demographics, but what doesn't make sense somewhat is the fact that the proportion of students that come from Black and Latino backgrounds have never really picked up. And so, I think this is where you start to think about, okay, well, we're expanding the definition of diversity. We're trying to think about all these other factors, but how do we still stay committed to making sure that Black and Latino students aren't left behind? And that is a struggle and a challenge as you start to broaden the definition of diversity. And so this kind of gives you a breakdown of what I just mentioned in terms of where everyone's at. So this is from 2011. I would say that the downfall is that this information is limited. Many times, again, it's not just about race, it goes beyond that, but this is sort of historically what we as a society have chosen to look at. And so you can kind of see that, it's harder to see here, but if you look at since 2000, since, Prop 187, since Prop 209, since a lot of the anti-affirmative action efforts have moved forward, there's been a drop in the number of Latino and African Americans who are applying compared to other groups. Other groups are either steady or going up. And so that raises a question again, what policies do we need or do we want to support to get more students of underrepresented backgrounds to go to medical school? And this is really interesting because, again, if you look at the #1 producers of African American physicians, you can see that by far, this is up to 2008, there's only 2 medical schools up there. I'm sorry, the two top medical schools that are up there, Howard and Meharry, are historically black universities. And so the burden of training black physicians is very disproportionate when it comes down to who's doing all the work. So the question is, what are all the other medical schools doing and how are they moving forward in trying to sort of address this issue? If you look at Latinos, the #1 producers of Latino physicians are in Puerto Rico. So we got Puerto Rico, Caribe, Ponce universities that have produced the most amount of Latino physicians. We do have UCLA up there. But again, that goes to just thinking about the production. It also goes to thinking about, well, where are all the Latinos concentrated? And it sort of makes sense. I mean, the data that I've included here includes all the students that get trained in Puerto Rico for Latinos. So if you think about the actual students who will end up practicing here in the United States, it's probably a lot less than what I've quoted. But it just goes to show in terms of the medical institutions where students are going. Maybe this is where they want to go. Maybe this is where they're concentrated, like in LA, Miami, Texas. You can sort of see that. So, it might not be a medical school issue. It might all have to do with where students want to go. But then the question that arises is, well, what do the other medical schools have to do to attract these students? In California, you can sort of see, again, the breakdown of the population to physician, and you can see the disparities in terms of the gaps where we only have 5% Latino physicians and almost 40% of our population is Latino. And the same thing with, the other groups in terms of African Americans, 3% African Americans here in California make up 6%. And this is just California data, but you can see some of the similar trends throughout the country. And in some places, this is actually more extreme. Because in California, we're lucky, we tend to have a more progressive, diverse state. So I'm going to open it up to questions, but I just wanted to summarize, if we have time. The representation of underrepresented minorities historically has been a dismal pool. It's remained stagnant despite population demographics. We're thinking about sort of now how we better serve patients, because we need to be more effective as physicians to get them to trust us, to get them to really feel like we understand them and we want to help them, and we want to practice in these communities too. Many of these communities are underserved, meaning that there's not enough physicians who want to even go there to practice. So how do we do that? And diversity is a catch-all term. I think when I think about diversity and for the most part and talk to people about it, people shy away from it. People don't want to talk about it because either they feel like this has nothing to do with me because I'm not diverse, or they feel like this has everything to do with me, but why are you singling me out, right? And I have students that I mentor all the time that are Latino, that are African American. They'll tell me I'm not diverse. And so it's a very interesting challenge, I think, as your mentors to really tackle this issue and help you figure out how you can sort of embrace diversity, enhance diversity, and recognize that it has everything to do with you no matter where you come from. And so that leads us to Diversity 3.0, where that's where we're headed, right? And that's you guys, that's your generation that's going to take a stand on these issues that, again, they've been happening for hundreds of years, for 100 years at least in terms of our talk today. But how do you reverse a lot of these issues? Many people would say, well, you just have to throw more money at the problem. And, you know, it goes beyond that. So I'm not going to go through that. So you can look at it both ways. You know, diversity could be the half empty or half full sort of perspective. And I would say that the disadvantage for you as applicants is if you take a half full approach, the medical schools will judge you pretty harshly. And so not only do you have to play the role, talk the role, but you need to back it up with your experiences, who you are, where you come from, what you want to do with your life. And so with that, let me open it up for a few questions before we move on to the next group. Can you stand up, say your name, where you're from, and then your question? Sorry.
My name's Davian Robinson. I am from Dallas, Texas.
All right.
My question is, does being a minority or URM help offset deficiency in your application?
All right. So the question is, does being a minority specifically, so being African American or Latino, or Asian Pacific Islander or Native American as previously defined, does that make up for a deficit in your application? I would say that in holistic admissions, anything can make up for any deficit, and it's not just your race. For the most part, I would say, like, for me, I was all about leadership and community service. And if you look at my CV, it's probably longer than most people who are professors, full-time professors, right? And so when they looked at my research, they were saying, well, you don't really have enough research. And so then I had to back it up with what I actually did and what I worked on. And so, you know, for the most part, I would say that when you're applying, and that's why you need a good mentor and advisor, we're all going to have deficits, right, in one thing or another. And you can use sort of your repertoire of experiences and experiences focused in on the things you really love and you're passionate about to make up for everything else, right? So if you hate physics, for example, and you didn't do well in physics, but you worked in a lab and you produced some really good research and you published it, that makes up for that kind of deficit. Now, I would say that if you look at the proportion of students who get into medical school by race, it's very similar. So you don't really have more Latino students getting in than white, than Asian. For the most part, it's very similar, and this data is available on the M.B.A. But what you do see is that, for example, a Latino student who is the first in their family to go to college, who has a lower GPA, will have a little bit of a slight advantage over a student who is the son of doctors or PhDs and maybe had that same GPA, because it's not equal, right? And that has everything to do with your training, your level of education, and the access to resources. So, all right. Thank you, guys.